Thank you to all the speakers, and we're all online, so we have a chance now for about 10 minutes to discuss this presentation, and I'll also encourage all the audience, if they want to put questions to the faculty through the Slido, they can do that. But I may start, and then I'll obviously co-chair this with Eva. But to Shelley, you've outlined that proposal, a new classification definition of heart failure, which I think has gone down fairly well. But it's interesting that you also presented the 4 stages of heart failure. And to me, there's an internal discrepancy in this, is that the document came down firmly that heart failure was a symptomatic syndrome. And yet the stages still are defined as the 4 stages of heart failure, including 2 that don't have symptoms. What's the intent of including the stage A and stage B in the overall ecosystem of heart failure, do you believe, and what's the clinical implications?
Well, I think ultimately we want to be put out of business as heart failure cardiologists, and there really needs to be a shift in society in terms of preventing heart failure as well. So I think that is a nod to preventing the progression. There are policies that could be put in place to reduce the number of people with hypertension and diabetes, and other motivating factors to reduce obesity, and all of these significant contributors to the development of heart failure. And that actually aligns as well with the World Heart Organization's goal to reduce the events such as cardiovascular events by 2030, I think it is, by a substantial percentage. So again, I think it's about shifting the needle to prevention and increasing awareness.
Okay, and while I've got you there, if I could just ask one other question. Do you think this will lead to better definition of heart failure around the world? We heard from Lars's talk the variations in the incidence, prevalence, and even background of heart failure. Partly, could that be explained by differences in how doctors and healthcare systems define heart failure, and might this definition help?
Yeah, I think it will bring us all to speak a similar language. I think that's important. A lot of us focus specifically on ejection fraction, and there's some variation in ejection fraction criteria based on inclusion criteria for various studies. And I think this gives us a reference language when we're talking about heart failure moving forward.
Okay, Eva, would you like to quiz any of the speakers?
Yes. I would like to ask the question to Professor Michel Komaida. We all know that the current guidelines prioritize the personal care, rapid implementation of different drug groups rather than sequential initiations of different drugs. Michel, do you think that this new approach will, first of all, improve the compliance in general in heart failure patients, and whether it will translate into better outcomes?
Yes, I think that it's a simplification which should make the life of cardiologists and practitioners who are treating heart failure patients easier. And I think that, as I said in my presentation, it's a major step forward. So I would expect that in the future we have a better implementation of what the ESC or other international guidelines would recommend, because it's a much easier scheme of introduction of drugs, and we do not anymore recommend this very lengthy stepwise approach with a progressive up titration of ACE inhibitors and beta blockers and then MRAs and then ARNI or ivabradine. So I think that these drugs, this way of advocating how we should start the treatment of heart failure patients will be much easier. I should add that the new class, which is SGLT2 inhibitors, is very simple because there is no titration at all, and it's usually one pill once a day. So this will also take part into probably the progress made in the implementation of guidelines recommended therapies.
If I could come in and ask Lars, you presented the global epidemiology, the percentage due to HFpEF, commented on the most prevalent etiologies. Are you struck by how different regions are or how similar they are? Do you think heart failure is becoming a similar condition around the world? I think you're on mute.
I believe the latter. I'm struck by how similar they are. So the numbers vary considerably, and certainly there are differences in predisposition, but heart failure is a global syndrome now with relatively similar background etiologies. And it doesn't so much matter if one epidemiological report suggests higher in one region and lower in another. And then I think instead, this is something that the whole world is facing, including countries in all income levels, with an increasing prevalence in all countries.
If I can have one more question, I do apologize. There's a question about initiating ivabradine in acute heart failure, and I'll come to Michelle, but I just want to broaden it out. Is for clinical trials, we've tended to act as if acute heart failure is an entirely separate disease, and we've done trials purely in acute heart failure. And yet we know that a treatment for heart failure is for life, and that we also know from registries that the most common point at which doctors make changes in medication is during the acute admission. Should we now consider that the hospitalization is the phase where most patients will actually be commenced on guideline-directed medical therapy and change our thinking about the hospital period as an opportunity?
Is the question directed to me, Andrew?
Yes, Michelle, please.
Well, I think it depends on the health system, because in some areas, the initiation can be made by GPs or in the heart failure clinics. But it's true that at least in the Western European countries, the hospitalization on the occasion of decompensation is usually the moment when heart failure recommended medications are initiated. I should, however, point the fact that what you said is acute heart failure. There are several phenotypes of acute heart failure, and we should definitely make a separation between those with a low cardiac output, which are less common, than those with congestion, either pulmonary or peripheral, which is the most common phenotype that we see during a referral to hospitalization for decompensation.